Good, af- Good afternoon, everyone. Welcome to today's clinically combined rounds. The first slot is presented by the Department of Endocrinology and Metabolism. Our topic for today is a tale of two patients, plasmapheresis as a rescue treatment modality in Graves' disease. Introduction. Overt hypothyroidism is associated with multiple organ dysfunction. Our conventional management of Graves' disease consists of three major options, either dictated by physician's experience or by patient preference, and includes antithyroid drugs, radioiodine ablation, or total thyroidectomy. Hypothyroid patients unresponsive to standard medical treatments remain a challenging clinical problem, and therefore, plasmapheresis is an effective bridge therapy to achieve rapid euthyroidism. However, it remains underutilized in treatments of refractory Graves' disease. Coming to two cases, the first patient was a 57-year-old male journalist from Noida, who had presented with significant loss of weight for 6 months, yellowish discoloration of eyes, and generalized itching. He was apparently well till the May of 2023 when he developed insidious onset progressive loss of weight of over 15 to 20 kgs over 6 months. This was associated with reduced appetite, nausea, and reduced meal portions. A yellowish discoloration of eyes and urine persisted since 3 months, associated with generalized itching and decreased stool frequency. He seemed to have no other complaints, no fever, abdominal pain, loose stools, no history of any mass lesion in the form of early satiety or abdominal distension, no history of neck pain or upper respiratory tract infections, and no swellings, constipation, or altered behavior. He had no history of previous blood transfusion and surgery. His personal history was significant only for an occasional alcohol intake, which was last 6 months ago. On examination, the patient did not have tachycardia. He presented with a very low BMI of 16.6. Clinically, he had no active ophthalmopathy. However, he presented with signs of loss of weight, that is, hollowing of cheeks and temporal loss of fat. Systemic examination was normal. On further inquiry, it was found that the patient had a chronic intake of complementary and alternative medication in the form of glycyrrhiza, oxalium, and solanum nigrum. Some of the investigations and treatment that were done prior to his admission and that were done outside AIIMS were as follows. As we see progressively from the 30th of July till his admission to 14th of October at AIIMS, the patient seemed to have a direct hyperbilirubinemia. He had also a thyrotoxicosis, however, that was quite mild, and alternative medicine intake was quite significant. However, he did not have any antithyroid drug intake at this point. He was progressively followed up outside, and multiple investigations show an increase in the bilirubin levels progressively. Multiple investigations were done. Neomocosol 10 mg thrice a day was added for 1 month, and this was his thyroid profile, that is, his thyrotoxicosis resolved. However, his bilirubin seemed to jump a lot. Some of the other investigations that were done outside included a TPO which was elevated, an ultrasound neck which was normal. Also, he underwent a thyroid uptake scan, which was suggestive of a diffuse toxic goiter. Gastroenterology workup done for hyperbilirubinemia, that is autoimmune, infective, and malignancy, turned out to be negative. An ultrasound abdomen was showing only gallbladder sludge. Fibroscan showed fibrosis without steatosis, and MRCP was normal. Interestingly, his hematological workup showed that he had a transferrin saturation of 95%, which was suggestive of a hemochromatosis-like picture. Hence, at presentation to AIIMS, this man had significant unintentional loss of weight with jaundice, with likely Graves' disease, with the etiology of his jaundice being either drug-induced liver injury, related to thyrotoxicosis, or maybe hemochromatosis. Coming to the investigations that were done now since his admission included a TRAB antibody level of 1.6. His repeat autoimmune, hematology, infective, and toxicology screens for his alternative medications turned out to be negative. However, his iron profile still showed a significant transferrin saturation, which led us to a red herring of hemochromatosis. His progressive thyroid profile, as well as his bilirubin profile, done over a period of 15 days during admission, showed that his direct bilirubinemia seemed to keep on increasing. The alarming rate of rise led us to do a liver biopsy, an FDG PET to rule out occult malignancy, an MRI for iron quantification to further confirm the presence of hemochromatosis, And lastly, the patient decompensated at 15 days with a raised PT and hematemesis.
So we had received the liver biopsy, and it comprised of multiple cores of hepatic parenchyma. And there was moderate to dense periportal mixed inflammatory infiltrate composed mainly of lymphocytes, neutrophils, eosinophils, plasma cells, and also there is presence of bile ductal injury, ductular proliferation, and presence of cholangitis. The adjacent hepatocyte showed presence of cholestasis, intracellular and canalicular cholestasis. On special stains, uh, there was hepatocyte damage present on the PASD stain, and there was lipofuscin deposition also. There is prominent cholestasis as demonstrated here with presence of ballooning degeneration, presence of spotty necrosis, apoptotic hepatocytes along with some regenerative changes. The reticulin stain showed altered framework of the hepatic parenchyma indicative of the mild cerebrolobular architecture. We performed Pearl stain, which showed extensive deposition of hemosiderin pigment, which is highlighted by the blue color, and it was deposited within the hepatocytes and within the Kupffer cells. This is the Mason trichome stain, which showed mild expansion of the portal areas and no nodule formation was seen. So, on the basis of histomorphology, we gave a diagnosis of cholestatic hepatitis with hemosiderin.
So in the background of this picture, we started treatment with lithium carbonate, 300 mg twice a day, and cholesterol. The liver biopsy, as discussed, was suggestive of cholestatic hepatitis with hemosiderosis. FDG PET did not show any occult malignancy, and the MRI ion quantification was not suggestive of hemochromatosis. Going further, we held the ENC discussion for a thyroid scan, which was suggestive of diffuse uptake in both lobes, which was suggestive of Graves' disease. Hence, a plan to further repeat an uptake scan and ablate the patient once the T4 levels reach 1.5 times the normal range was done. However, in view of an unknown etiology of the hyperbilirubinemia, ablation was deferred for the time being. A gastro review at the same time done, which in view of bile cast nephropathy, a deranged INR and hematemesis, the intolerance of patient to cholestyramine, no decline in bilirubin levels over 15 days, and no etiology found in liver biopsy, a plan for plasmapheresis was taken up. So the patient underwent 4 plasmapheresis cycles as detailed. Here we see that the bilirubin levels significantly seemed to drop from an initial 25.9 to direct of 22.4, and after the 4th plex cycle, it dropped to 10.1. The pre-T4 levels remained stable, however, at a point they were actually seemed to rise. The patient was also started on Vizolone 20 mg only, considering an etiology of query autoimmune hepatitis. Post the second plex, patient's pruritus resolved, and the patient started to show gain in weight. A further uptake scan, which was done, suggestive of a 2-hour uptake of 4.9% and a 24-hour uptake of 11.2%. As there was low uptake, ablation was deferred, and the patient was kept on gastro follow-up with trabelprednisolone 20 mg once a day. These are his follow-ups 1 week, 3 weeks, and 5 weeks after the last plex cycle. We now see that the direct bilirubin seems to stabilize. The free T4s and the T3 levels have also remained stable. The transferrin saturation, which initially remained more than 90%, came down to 48%. Weight gain improved as well as the appetite improved. The patient was kept on follow-up for over 3 months with trabelprednisolone. He had no requirement of antithyroid drugs, and his latest follow-up at 3 and 6 months show a resolution of bilirubin, thyroid profile, improvement in body weight, as well as decrease in transferrin saturation. Coming to the second patient who presented within a month of the first patient, a 20-year-old unmarried lady from Rampur who presented with history of loss of weight, fatigue, weakness, palpitations, yellowish discoloration of eyes, and abdominal distension. She first presented to gastro OPD with progressive unintentional loss of weight for over 1.5 years, associated with increased stool frequency and appetite, fatigue, weakness, and palpitations in 6 months, with inability to do work and easy fatigue, painless jaundice, abdominal distension, and bilateral period edema. With these complaints, and on further inquiry, we know that she also had a goiter, which was present since more than 3 years, and she remained on and off therapy with antithyroid drugs. She also developed generalized hyperpigmentation and a staring look in the form of reduced blinking and lid retraction with increased grittiness in the eyes. She seemed to have no history of vasculitis work. On examination, she also presented with a low BMI with no signs of active ophthalmopathy, hollowing of cheeks, and temporal loss of fat. Systemic examination was significant for an abdominal distension, dilated veins, and hepatosplenomegaly. Investigations done prior to her coming to AIIMS included a pancytopenia in the form of dropped hemoglobin, total counts, as well as platelet counts. She also seemed to have a direct hyperbilirubinemia and a significant thyrotoxicosis. Here, the patient was first evaluated in view of her jaundice and ascites, and a CCT abdomen was done, which was suggestive of a hepatic venous outflow tract obstruction. In this CCT abdomen, iodine contrast was used, and hence we could not further work her up in view of her thyroid illness. In view of pancytopenia, bone marrow biopsy was done, which was suggestive of 70% cellularity and a normal trilineage metapoiesis. A biopsy was done to see whether the bone marrow was hypercellular because we suspected that it was a hypersplenism which was occurring and which was leading to the pancytopenia. The further autoimmune workup was also negative. A technetium thyroid scan was done, which was suggestive of a diffuse toxic goiter. So initially, the patient was under gastro in the gastro inpatient department and was started on neomycozole 10 mg TDs. But in view of a declining WBC and ANC, that is absolute neutrophil count, we thought it could be a drug-induced decline in this cellular level, and hence we decided to stop neomycozole and started on lithium and cholesterol. And giving her a re-challenge after a week, we found that there was a further decline in her absolute neutrophil count levels. And hence, we could not reinstate her on neomycozole therapy, and we continued her on lithium and cholestyramine therapy. Her thyrotoxicosis seemed to worsen with stoppage of neomycozole therapy. In view of patient denying TIPS intervention and treatment options being limited, and in view of ongoing pancytopenia, it was decided that the patient will undergo PLEX therapy, followed by radioiodine ablation. This patient has now undergone 8 PLEX cycles at intervals of 2 to 3 days, and we now see that her cellular counts actually shown an improvement except for the platelet levels. Her TFT profiles also improved with time, and she then underwent an uptake scan and later ablation. So the patient underwent a radioactive iodine ablation on the 2nd of January after her 7th PLEX cycle. However, she was not able to tolerate this, and post-procedure, she did develop some dry cough and fever, and it was suggestive of a lower respiratory tract infection with a lower zone consolidation on her HRCT scan. Finally, an 8th PLEX cycle was done on the 5th of January. However, the patient went LAMA even after multiple counseling sessions. So as a case summary, we have 2 patients, one an elderly male who presented with unintentional loss of weight and jaundice, conjugated hyperbilirubinemia, which was severe, while a 20-year-old lady who presented with jaundice, ascites, and a significant pancytopenia with a mild conjugated hyperbilirubinemia. Both of them were hypothyroid. Both of them required alternative drug therapies where neomycozole could not be used. Both of them underwent multiple cycles of plasmapheresis. However, in the first patient, we are still not sure what the etiology remains, while in the second patient, we were able to give her biochemical cure with plasmapheresis. Coming to the review of literature, overt hypothyroidism is associated with multiple organ dysfunctions, including the liver. Hepatic dysfunction may range from mild transaminitis and cholestasis to liver failure. The relationship of this to severity of hypothyroidism has yet not been established. Reversibility is seen with the restoration of euthyroid state. Thyroid and liver have a major interrelationship even during health, with thyroid hormone controlling basal metabolic rate, bilirubin production and composition, and Uri specters release, while the role of liver stays in synthesis of thyroid binding globulin, prealbumin, albumin, peripheral synthesis of T3 and reverse T3, excretion by glucuronidation, and liver extraction of T4. Thyrotoxicosis and hyperthyroidism are also seen, that is, they also show transaminitis. Different mechanisms that cause this include increased oxygen uptake with relative hypoxia, apoptosis, and oxidative stress. High GGT levels could be due to cholestasis, and alkaline phosphatase activity can be contributed by bone also because there is increased osteoblastic activity in thyrotoxicosis. Hence, transaminitis is commonly detected at the onset of Graves' disease, with a prevalence ranging from 37 to 78%. Raised alkaline phosphatase is also seen in nearly two-thirds of studied cases. Antithyroid drug side effects, that is the agranulocytosis and hepatotoxicity, are very rare, with a frequency of 0.5 to 0.1%. The patterns of liver injury have been studied in multiple case series. Presented a series from UCLA, USA, where from 2002 to 2016, they've shown an overall incidence of any liver function test abnormality within 6 months of onset of thyrotoxicosis. Significant predictors have been an initial serum TSH level, which is suppressed below 0.02, male gender, and the African American race. Another retrospective data, which was released by the Mayo Clinic, shows a lack of dose-dependent relationship between T3, T4, and liver dysfunction. There seem to be direct hypermetabolic pathways, which are a principal etiology of liver dysfunction. However, this theory seems to be an oversimplification. There appear to be multiple transporter-dependent and intranuclear transcription factors that likely play an important role. And therefore, the predictability of which Graves' disease will undergo cholestatic hepatitis is not known.
So plasma exchange is plasmapheresis is a umbrella term which includes the collection of plasma along with the plasma exchange. The mechanism behind TPE is removal of pathogenic substances and delivery of deficient plasma components. We received two cases, two requests, and first we have to decide the diagnosis. And according to the diagnosis, we decide the case by ASFA guidelines. The latest one is 9th edition 2023. So according to the ASFA guidelines, the cases are divided into 4 parts: category 1, category 2, category 3, and category 4. The thyroid storm falls under category 2. Uh, when we got the case, we have to first do the diagnostic workup, which includes biochemical investigations, CBC, coagulation, disease-specific test, infection status, and blood type. The monitoring is done to assess the efficacy of TPE along with the tolerability of the patient, which includes biochemistry, CBC, coagulation, and disease-specific test. According to ASFA guidelines, the thyroid storm falls under category 2, grade 2C. The rationale being the patients responded poorly to first-line therapy within 24 to 48 hours of treatment, or where first-line therapy can't be used due to toxicity such as leukopenia. A portion of thyroid hormone binds with the plasma proteins. TPE should effectively remove their circulating pool with resulting decrease in hormone secretions. Autoantibodies in Graves' disease, catecholamines and cytokines are also removed. The replacement fluid used is plasma along with albumin. The volume treated is 1.1 to 1.5. The frequency we had done daily or 2 days after. The duration and the discontinuation, we had done eight procedures, and we got the clinical improvement after that.
So, therapeutic plasma exchange in refractory hyperthyroidism has rarely been studied. There are two major case series, one which was done in 22 patients of refractory hyperthyroidism, doing a total of 91 plasma therapeutic exchanges. After these exchange levels, we see that the levels of free T3 and free T4 before and after all sessions of TP, there was a significant decline in both. And after TP, we have to remember that plasmapheresis is not the definitive management, it is just a bridge to therapy. And therefore, definitive management in the form of total thyroidectomy or in the form of radioiodine ablation is required. And they've shown a successful outcome in 22 patients who have undergone plasmapheresis. Similarly, another study which was done showing therapeutic plasma exchange in refractory hyperthyroidism, the etiologies ranged from toxic goiter to multinodular goiter and even amiodarone-induced thyrotoxicosis. The mean plasmapheresis sessions in these patients were 5, and there was a decrease in the mean free T4 and free T3 levels by 57 and 73% respectively. And euthyroidism was achieved in patients with radioactive iodine in 1 and medical therapy in 3 patients. Coming to the second case, the lady who presented with Budd-Chiari and thyroid dysfunctions. Doing a review of literature, we could only find 2 cases, that is Budd-Chiari in a patient of type 1 diabetes. Here she presented with hypothyroidism and was kept on levothyroxine sodium supplementation, which was reported by a Japanese society in 2003. And another patient of Budd-Chiari with APLA with Graves' disease. And here the patient actually presented with Graves' disease and was retrospectively found to have Budd-Chiari, which led to the association with antiphospholipid syndrome. and this triple association had not been previously reported in literature. So coming to the take-home points, jaundice, severe cholestasis, and hepatotoxicity in the absence of pre-existing liver disease can be a rare first 50% of thyroid hormone levels. Therapeutic plasma exchange is therefore a rescue therapy for refractory hyperthyroid patients when medical managements are contraindicated or have failed to restore euthyroidism. Attaining a euthyroid state as hepatic recovery is critical, as hepatic recovery can lag behind that of thyroid by several weeks. And a big shout out to all the departments that helped us in managing these patients. Thank you.
Thanks, Preeti. I'll just preface this by a small. So actually, this has been very useful and learning experience for us. In the first case, both cases are planned to prepare the patient for radioactive iodine ablation. In the first patient, we actually managed to get away without that. Possibly it was a milder disease and maybe had very low levels of TRAB, which might have got taken care of by plasmapheresis. So we're doing fine there. The second was actually stormy. The second patient was actually transferred from gastroenterology. Clearly, multiple significant problems. Fortunately, with the plasmapheresis, we could ablate the patient. Unfortunately, we don't have a follow-up. But it really tells us that, as what I was just talking about with Chumbar, that Graves in between throws up sort of very interesting manifestations. From the pancytopenia, the agranulocytosis, we see not infrequently, and there's standard protocols for that. But both these patients gave us a lot of difficulty in terms of how to manage, and we're really grateful to so many departments which came to our rescue. And I think that's the sort of the joy of working in an institution like here, that you get a multi-departmental buy-in for that. I won't say anything more, but I'd request Dr. Shalimar, who was sort of centrally involved in managing the second patient, and then, of course, open it up to questions, comments, and discussion. Very actually speak to. We thought possibly what was the difference so thought possibly and the next option was an option. So there's a lot of now evidence coming in liver disease. A lot of that's the reason why we thought, okay, why not? This patient was not showing any kind of response. Whatever treatments we were giving, we don't have much treatment for liver disease. So we thought, okay, why not start plasma exchange? And the first patient showed really good response. And I do remember that we gave my OP a couple of months back. And we were very happy that the same patient who was such a evacuated, sarcopenic patient with such a low BMI was so well improved with that kind of therapy. And actually, in phase got better than probably the steroids. And was started to work both for drug use, autoimmune. We really don't know what the diagnosis was. So I think the plasma exchange definitely has to really thankful to who support us with plasma exchange. Our indications will be on because they do have their own indications, but then we push them wherever we have liver disease. When we don't find anything, okay, let's just try plasma exchange. So it's like we gave our opinions. That was our plan, and we advised the plasma. So the first patient was actually milder thyrotoxicosis. There was some mild hyperbilirubinemia even before starting antithyroidals. It was a bilirubin of about 1.9. So we don't know why that was there, but that patient was not severely toxic enough to itself directly contribute, though there is, as Preeti mentioned, there isn't a strong correlation between circulating T3, T4 and the liver enzyme levels. But he really had we started with 1.9, it came to 32, 34. It was just really, really high, and that was there. The second thing is whether there's a causal relationship. So again, you can get anti-endothelial antibodies with Graves, just like you get so many other antibodies, whether they contribute to thrombosis and whether they were responsible for the hepatic vein outflow tract obstruction, we don't know again, but it's an important speculation again. So it just suggests that a lot of these so-called organ-specific autoimmune disorders may actually have
an effect outside the organ of interest because of additional autoimmune phenomena. But comments, and again, and let me also reiterate what Dr. Shalimar mentioned. We really need to put on record our gratitude to everybody, specifically transfusion medicine in this particular instance, and their contribution. Really, we sincerely acknowledge what they did for both these patients. We have all the other departments which regularly we trouble nuclear medicine day in and day out, and they've always been extremely supportive. And of course, you saw the range of antibodies and the range of other investigations done, and I'm not sort of calling out each department, but we really have depended on every one of them to give us support to manage these patients. Dr. Rajesh and then Dr. Bal.
And first patient was really difficult because he was journalist with an active mobile. So what
Dr. Bal. Do you want to use that microphone? You can come. इधर आ जाओ, इधर आ जाओ.
The standard drug we use for antithyroid disease management is neomercazole and methimazole, but P2 is sometimes very specific indication. Otherwise, if they are toxic to the patient or they are hypersynchronous or they are hyperactive, the patient do not tolerate them. We have only left with lithium, which is not a very good drug, agility. What it does, it only prevents T4 to T3 conversion. So you can just keep the T4 level high, but it is nothing to do with the synthesis. So we had a very good drug which was used in late 80s and early 90s, and we had done some work on this. Is the oral cholecystographic contrast agent, hyperonic acid, ipodate. And we had, in 1958, somebody published in Journal of Clinical Endocrinology Metabolism, a radiologist showing in 71 patients that if you give this contrast, you can never use to treat them with radioactive iodine. And my first work in nuclear medicine was on that. So I give 1 week antithyroid, this iponate, and then off for 1 week. And 14 days, I demonstrated 92% of them, they're ready to be treated with radioactive iodine. And that got published in Journal of Nuclear Medicine. And I continued, at that time, senior faculty, I continued working and I published 110 patient data on Journal of Clinical Endocrinology Metabolism, same journal, as a full article, showing that you can treat all of them and their long-term outcome is no way different. But unfortunately, because of the ultrasound, it has killed this oral contrast. So the drug is out of market, but the utility is still there. You can use it if the companies are there. Somebody, Days Pharmaceutical in India used to manufacture these drugs, but it's not there. So this is one drug which is very useful in crisis, impending crisis. You can use within 24 hours the T4 level from 24 drops to 10. So T3 level disappears with the T3 has got short half-life within 24 hours. T3 will be bang normal, patient will be much better. And because they propagated that it will never be used for radioactive iodine, we demonstrated that it can be treated with radioactive. So these are all new information we provided, published, but unfortunately the drug went out of market.
Yeah, thank you. I think we'll give a minute back to surgery. And I'll recall it when future, if we ever want time, we'll take it back also. Thank you so much.